Rob, thank you for having me. My name is Dr. Michael Carroll. I'm a practicing family physician in Traverse City, Michigan. I have developed a special interest in treating shoulders, and that is born of a huge number of people that I see with shoulder pain that have not done great with traditional modalities, I would say, and they have been looking for something else. And so I, with my team, have developed a product called ROTATOReliever, and that has been it's something we've been working on for a while, and so I'm looking forward to talking about it today.
Great. Now, tell me about when that started, because if I recall, I think I saw this a few years back, or something quite similar, and then didn't have a real high profile. But recently, I think we saw you coming back stronger. What can you? Am I putting things together right there?
Yeah, absolutely. So we have, yeah, I mean, it was kind of like probably started, kind of way back in maybe 03, 04, when I was just sort of essentially a few years into my practice, and also suffering from some shoulder pain. And one night I'm sitting there and I'm like, oh my gosh, it feels better if my arm is in a little bit of traction and kind of down. It felt like I had immediate shoulder pain relief, and the next day it was dramatically improved. And so, being a young guy, I think you discover something and you think the whole world needs to know about it. And so I was enthusiastic, and I was also enthusiastic about not want to be a guy clanging a bell about an idea I had, in the sense of I wanted to be backed up by research. So, I mean, the absolute, just after we made some prototypes and used them on some patients, we put kind of a substantial amount of money behind the product, and did some great research that we were able to publish in the American College of Sports Medicine Journal. We were able to present it in, it took us a little while, but I did present that at the 2006 American College of Sports Medicine National Meeting, and it was great. It was one of these things where it was kind of like it was a pilot study, but it was strong enough to reach the statistical significance. And so we kind of made a little bit of a splash with that. So that's kind of how we started, I would say.
And then have you, is it just my perception, or have you put a little bit more oomph behind it recently?
Yeah, I mean, the story sort of, I presented this research in 2006, and I'm like, I'm like, boy, I can't wait till the captains of industry come to meet me after I give this talk, and they're gonna congratulate me on what a great idea I had, and it's gonna be cake and ice cream after that. And so as it turns out, no one spoke to me after I gave that talk. I mean, a few doctors did that were kind of excited. And so I start chasing down these companies, and I'm like, hey, I got this thing that, we've got research. It works there's like a gazillion people with shoulder pain. And they're like, you know what? We don't introduce anything, Dr. Carroll, that is, we have no new products under about $275. So, thanks, but no thanks. It's, we're not interested. And so, I was kind of licking my wounds a little bit after that. And then I said, you know what, this is crazy. I keep seeing these patients in my practice. My patients really have kind of driven this product. And so I said, I got to make this direct to consumer, because, it's, no one else is kind of interested in it. And so we were able to do that. We added an exercise component that has been as important as the nighttime brace. And we've had so then I got that together about 2010. And then, I'm in a small town in northern Michigan. We launched it And it was, I think maybe part of it was me and my, I guess, business acumen at that time. I'm not sure if it's much better now, but and certainly I don't think that there were a lot of people around me at that time that had experience in sort of developing a national product. And so, I was confident. We had ordered 5,000. We did eventually sell all 5,000, but it was kind of, we never quite got the right team to market. You got to tell your story. And so we had challenges with that part of it. And then I sort of like go on and on here, but so, we were selling the last of those 5,000 and it was kind of like straggling. And I'm like, probably in 2017. Okay. So maybe, what is that? That's like 7 years after launch. It was kind of dying, frankly, and not because people didn't want it. I mean, come on, we sold 5,000 of them, and and people were sort of clamoring for my last ones, and I felt so kind of empty inside. I'm like, God, I was close. We are almost there. And so, with that kind of rally cry, we got the team, like sort of got a different marketing team, and, and myself a little bit seasoned, and, we've done a better job of it. And I think that we've had a fair amount of success getting our message out. And so that's a very long answer, and I apologize, but that's kind of where we're at.
No apology necessary. Might you have one right there with you in the office?
Hold on, uno momento. I should, but I don't. Wait. Hey, Jordan, grab me a rotator reliever, will ya? This one's missing a handle. Okay. Rob, I got one. Well, I got part of one, but so this is it's a system, okay? The rotator reliever, Rob, is a so it's a daytime, nighttime program. And it is, the initial innovation we had, or I had, was that people are hurting themselves at night. That basically you lose gravity, you're horizontal, maybe you're sleeping with your arm under your cheek or your arm above your head, and that clamps off the blood supply to the supraspinatus. So, these people, you've talked to them, they're sort of rolling around all night, they're in pain. So we put so our nighttime positioning is we basically connect the wrist to below the knee, and that helps the shoulder. And so the thought is that it basically, keeps the blood supply open. It's simple. Most shoulder pain, the vast majority is driven by this impingement syndrome. A lot of that impingement or pinching happens at night. We get rid of that. We break that part of the cycle. Super critical, in my opinion. And then, so that's it. And it's a 40-day, 40-night treatment program. And and then the daytime component of it is also super important. there's 17 muscles that attach to your scapula, and I can tell you right now, we only want 4 of them stronger, okay? And in my opinion, and so the rotator cuff, which is the 4 muscles, it's a stabilizer, okay? It's a stabilizer. It doesn't like cause the massive movement of the arm, okay? But it keeps the ball centered in the socket. And I think that, I feel like we are, why does this pinching happen in the first place? It's because, in my opinion, and, we got some ongoing research to help us, talk about this more. And it is that we have a muscle imbalance. The 4 muscles of the rotator cuff are too weak compared to your deltoid and your pectoralis and your trapezius that are moving it up. So our exercise is the ultimate sort of demonstration of dynamic stabilization. So your arm doesn't move in our exercise, absolutely does not move. but you're getting a deep muscle workout from the shoulder stabilizers. It's basically you're spinning a ball on the end of a string. Okay. And then we have these, they're kind of like sequentially weighted balls. You work your way up, and it just it's one of these things where you're like, why didn't someone invent this like 80 years ago or something? I mean, it's a pretty simple idea. Okay. And I mean,
let me dip into your theory here a little bit, because I find it fascinating. I think in one place you cited a study that I've been trying to find, and correct me if I'm wrong, but that there's been a large sample done of imaging done on people over the age of 60 or over the age of 65, and some half of them showed asymptomatic rotator cuff tears.
Right.
What am I referring to some work that you cite someplace along the line?
Yeah, absolutely. I mean, Dr. Anderson, James Anderson, the guy who, I think he might be retired, but he did all the orthopedic research. I mean, he did an MRI study in athletes, and he's like, 97% of these MRIs have got, problems with them. So, I mean, the MRI, I would argue, is kind of an overly sensitive test. But yes, the research that is referencing is basically 100 60-year-olds were imaged that reported no shoulder pain. And 60% of them had some, small tears, basically, in the, one of the four muscles of the rotator cuff. Now, granted, most of those were in the supraspinatus. So it's kind of like, if you looked hard enough at a 60-year-old's meniscus, that padding in there, the padding in the middle of their knee, everyone's got a dent or a ding or a, so, I mean, the rotator cuff is kind of a more resilient structure than a lot of people think. I mean, hey, you got a small tear. Doesn't mean you need a needle and thread to bring it back together. We just need to rehab what's left of your rotator cuff, and most part you do really well.
What role do you think inflammation is playing in that pain factor?
Well, I mean, I think that the inflammation is certainly, it drives kind of all pain except neuropathic pain, and it drives some of that. So I think that it's associated with it, but this is not, it's primarily an anatomic issue. I mean, this engine of shoulder pain is being driven by pathologic anatomy. And so, you can either alter anatomy with surgery, or you can alter anatomy by rebalancing muscles. So,
well, that's fascinating. So, when you have a patient come in and they're presenting with shoulder pain, the typical pathway is from a primary care perspective is, I'm going to pass you on to an orthopedist. They're going to do an MRI. That MRI is going to show a tear, and then that's licensed to schedule a surgery.
Yes.
And the surgeon, when they come out of surgery, man, they're even in worse pain, and they're in it for a long haul. You're interrupting that.
Yeah, I mean, it's like, I think that I always have to check myself at this point. It's like, I've got some good friends, and every town needs an awesome one or two shoulder doctors and shoulder surgeons, I should say. And we have that. Okay. But that being said, everything you said is correct. I mean, I would say the rule rather than the exception is what you've described. And there are many, many people who don't get a crack at, who do not get a crack at any therapy at all. And they're on the table getting a surgery that is like, those are big surgeries.
Yeah.
And they have a prolonged recovery. And so, yeah, I mean,
so tell me Tell me what happens when a person comes in, because there's people who come in after a fall. And then there's the typical patient. Our typical patient is someplace to the left or right of 65 years old. And,
Mhm.
and things are wearing out, and they have shoulder pain. Some of them have arthritis. Um, but for the most part, our patients are about 50% non-operative and 50% post-operative. And if I'm able to extrapolate from what the CDC says, there's about 10 million visits a year in the US for shoulder pain, and something between 500,000 and a million surgeries. So 9 out of 10 aren't getting a surgical intervention. Tell me what it looks like when a patient comes in and says, "Hey doc, I got this pain in my shoulder." Do you do any imaging, or do you step right into, do you do a simple shoulder test on them to see if you can somehow predict what the problem is? Kind of run me through what typically might happen when there's pain.
Well, I mean, I think that what I do as an individual physician is critically important to my patients, but as it relates to a direct to consumer product, which is what we have,
Right.
I mean, basically, I'm of the belief, based on research, that about 92% of shoulder pain is driven in some way, shape, or form. I mean, maybe there's a labral tear as well, maybe there's some arthritis, but I mean, shoulder pain it's a rotator cuff story, okay? And so it is, as it relates to rotator reliever, we're like, are you kidding me? I mean, try the product before you do anything.
That's right.
I mean, it's like, I can tell you what I provide as a physician. I mean, yeah, okay, I'll do an exam. I'm gonna take a great history and do a good exam, and I'm probably gonna tell you got rotator cuff, problems. And right, if it's a prolonged time frame, I think that, there are definitely some people that we want to get into surgery sooner than later, but that's about, I mean, about 90% of people with shoulder pain cannot relate it to a specific injury.
Right.
They're just like, they just show up and they're like, man, this thing's been killing me for a long time.
When you say I'm going to do traction and then daily traction and daily exercise, I imagine you get some hesitancy because their shoulder already hurts. What kind of, let's just talk about the people that you're going to see back in your own setting there. Are you saying,
yeah,
try and let's talk again in a week, or what? Tell me what. Give me a
well,
feel.
I mean, it's somewhat, it depends on the severity and some of the longevity. I mean, sometimes, like, if they're I mean, I saw a guy today, he's got Parkinson's disease, a bad shoulder, he's using a walker, and that's really tough on the shoulder. And like, there's no way that this guy, he's got a ton of other, really difficult health stuff. There's no way this guy's going to get his shoulder surgery. And this guy, I didn't do imaging, and I gave him a steroid shot and and even him, he doesn't even, he didn't really have I gave him some exercises that, I feel kind of approximate what my product does. I mean, to a lesser degree, but he couldn't handle it. But he could handle a shot, and I think he's going to do great. I think that, so obviously it depends, where you meet, where these people are. There's a lot of variables, I should say, but for the most part, they've got some shoulder pain. It's not related to a recent massively traumatic event. And, they've got some chronic shoulder pain. And so I basically will talk to them about physical therapy, and many I will send to physical therapy. Some people are kind of minor. It's really not that bad. And I can just basically give them some exercises, maybe do a shot, but if it's minor, I probably wouldn't do a steroid shot in the subacromial space. And then some people I'm like, listen, you've already failed therapy, or you know, you don't have time for therapy, or you can't afford therapy, or you don't want to go to therapy, then just, you know, buy the rotator reliever and use it. And, you know, turns out they get better. So
let's talk about the traction portion a little bit, because in my mind's eye, what you're really doing is opening up the subacromial space, and you're probably, you know, doing the opposite of impingement, which is opening up for more blood flow to the damaged tissue. Is that theoretically where you're going there?
Yeah, I mean, definitely theoretic. I mean, I think that, you know, and I was, you know, when I first brought the product out, I was like, you know, the direct traction is like, you know, is really the key. But as with time, I've come to realize that, you know, there's some traction, but the biggest benefit of that nighttime brace is it keeps you from sleeping on that shoulder. Okay. Because if you can't bring your hand up to like somewhere around your face, you're not going to sleep on that shoulder. Okay. And you're not going to sleep with your arm above your head. And those are the real killers as far as, you know, in my opinion, as far as cutting off blood supply. So,
yeah. Well, that was fascinating. It sounded to me like you did traction first and then added the exercise, or did it all come together?
Yeah. The first research was just, you know, we reached statistical significance on, you know, just really the nighttime component. And, you know, obviously we think the daytime component is critical. And, you know, we think that, so anyway, our ongoing research is like an MRI study to see if we can, you know, show that we open up that subacromial space. So that's what we got going on.
Okay. Well, congratulations on a very interesting innovation. And
thank you, Rob.
Which I believe makes total sense. It probably doesn't make as much money as shoulder surgery does. But
yeah. I mean, that's true. That's true. You've nailed that part of it. Yes.
But it certainly fits with what I'll say a more logical sequencing of conservative interventions before, you know, undergoing either an arthroscopic or an open surgery, or even a total shoulder replacement or reverse total shoulder. I'm not saying that's not right for people. There obviously are people that have benefited from those things, but I think jumping the line and going right into surgery without trying some logical alternatives on the way there is something I'm opposed to. What about post-op? Have you seen your device used post-operatively?
It's a great question, and yeah, we've got a lot of, you know, I mean, I communicate a lot with like you know, customers and potential customers, and it's like, yeah, I mean, our product works great post-op, you know, but yes, you should, you know, talk to the surgeon and get the surgeon's blessing. I mean, you know, I'm not trying to intercede on any doctor-patient relationships, and you know, and also, you know, I'm pretty diligent about like, hey, listen, I mean, here's what we've proven and here's what we haven't proven, you know, and I'll tell you, our research is you know, we haven't done the post-op research, but yeah, we think it works great post-operatively. And, you know, I haven't run into any surgeons who have, you know, been like, no, that's going to put our anatomy in danger. I mean, it's pretty gentle therapy, but it's basically, you know, getting that, if you're spinning the ball, you're getting all those muscles of the rotator cuff to fire kind of sequentially. You know, there's a lot of neuromuscular connections that I think, you know, the body shuts down when there's impingement and inflammation. And we're trying to get that little fire going again. Fire is a bad term. We're trying to get that little communication going again. And that is, yeah, I mean, I think the surgeons, you know, I mean, I'm not sure they love this product, but, you know, they've been open-minded about using it in the post-operative setting. And, you know, my anecdotal report to you is that it works great in that setting. So,
are you doing any registry kind of work where you're maybe not doing a controlled trial, but doing follow-ups with perhaps pain level and range of motion measurement and strength testing. I find from the non-medical side, even automotive industry, building a data set that records improvement from some common starting point is informative. If it's not necessarily scientific, it certainly provides more insight into what works and what doesn't work.
Yeah, I mean, it's all scientific if you're going to do it right. I mean, I think that it's like, hey, there's a, you know, we are small, we are starting in a lot of ways. We are, you know, funding one research. We've already funded one research. We got another one that, you know, we're putting money in and we're trying to raise money for. So yeah, I mean, and then I think that so that is, you know, the thing that I like is the simple shoulder questionnaire. I mean, it's a standardized measurement tool. It's fantastic because it's not really dependent on the physical exam. It's function and pain. You know, and you can do that interview over the phone. So that becomes more affordable as far as research goes. And I think it's reliable because and actually it doesn't matter what I think. It's been proven reliable.
It's consistent.
And so, and consistent. And, you know, it is a vetted standard question for measuring, you know, shoulder pain. So
I think that's a University of Washington product too, if I recall.
Well, I like the Huskies. So my recollection was UCLA, but maybe I'm clouded by my recent you know, success with them in the tournament. So
One
I don't
final
know.
question before we sign off on the recorded portion here.
Yes.
What about frozen shoulder? Have you experimented with?
Oh my God, I get that question. I get that question daily. Okay. And I mean, all right. So my standard kind of like, all right, you're getting my opinion. Okay. You know, I think that because I haven't done that research, but we have 10 years of, you know, experience, you know, kind of have to take me at my word about what, you know, how people do. I can tell you, they do awesome. Okay. I mean, you know, it's the same, you know, why can't people move their shoulders? Okay. It's because they're locked in with inflammation because the rotator cuff is not working.
Right.
And, you know, that's what I think, you know, happens. And it's like, you know, let's say a windmill is stuck, Rob. Okay. A windmill is stuck. You know, are you going to go and just like pull on the arm of that windmill? Or are you going to go to the center and see what's not quite working right there? And I think that, so, I mean, I think that it's super important to get that neuromuscular connection, get the rotator cuff functioning again. And I mean, you know, I think if you don't have that, it is hopeless to get, you know, thinking you're going to get frozen shoulder better. I mean, I think you've got to take care of the rotator cuff and the frozen shoulder. Forgive the pun, but the frozen shoulder melts away. Okay, so that's my opinion, and you know, someday I'll have the research to back it up, and but I mean, you know, rotator or frozen shoulders, it's tough to do research on. It's tough to get people to agree on the diagnosis, frankly. So, you know, but that's my take on it.
Yeah, my first question is always, well, tell me what you mean by frozen shoulder, and let's take it from there. You know,
Yeah.
There's no common consensus there. So
yeah, it's super hard to get the standard. I mean, it is. Yeah, I mean, it's hard enough to get you know, agreement on rotator cuff tendonitis. So,
well, Dr. Carroll, thanks for letting us record this interview today. Where would we send a therapist or a patient if they wanted to get your product?
Well, I mean, the best thing would be to go to my the website, ROTATOReliever.com, and I will say this, Rob. Okay, this Rotator Reliever name has been my cross to bear, and actually, very shortly, I will be changing it to a funner, better name and more descriptive. So, but right now, they can go to ROTATOReliever.com. and get it. Okay.
All right. Thank you very much.